Ready to our ILPQC basic kickoff Teams call. This is a 2-hour call. Usually our calls will be just 1 hour, but we had so much information to share during for the kickoff meeting that we made this one 2 hours. I am, for people who don't know, I am Leslie Caldarelli. I'm a neonatologist at Northwestern and Lurie and one of the neonatal co-leads. Let's just go around. Justin, will you introduce yourself?
Yeah, hi, I'm Justin Josephson. I am also a neonatal co-lead. Chris, I know we all know a lot of you, but when I look at our participants list, we have a lot of new faces. We haven't encountered as much. So we're all glad you're here. I'm a neonatologist at Cardinal Glennon Children's Hospital in St. Louis. And of course, our hospital in the St. Louis area in general serves a lot of babies from Southern Illinois. And Leslie and I partner together to clinical leads.
For that, you could just get
And
one
so,
of them.
can everybody who is
I can help you with today.
Hey Leslie, you got on mute by accident. Can everybody who is not presenting please go on mute? Thank you.
Sure. Dan, will you introduce yourself? Because I know there's a lot of familiar faces, as Justin said, but some and voices, but lots of new people too.
Hello everyone. My name is Dan Weiss. I have a cool headset today. I am an ILPQC project manager and one of the point people helping orchestrate this initiative with you all.
And then who else from ILPQC is on? Ellie?
Yeah.
Yes. Hi, I'm Ellie Seuss. I'm a project coordinator with ILPQC, and I will be helping out with the basic initiative, and I also have experience working as a labor and delivery postpartum and NICU nurse.
Hi, Ellie. Anybody else right now? Okay.
No, it's me. Can you hear me? I'm Agatha Sowsrall. I work at Northwest Community Hospital, and I belong to ILPQC, the antibiotic stewardship.
Welcome. We're gonna hold on introductions from everybody else because we have a jam-packed agenda. And I, as everybody on the call knows, or will know when I say this, I'm on service. So we're gonna tag team the call, but if I get pulled away, that's where I've gone. So with that, let's start. Am I in charge of slides?
Justin is.
Justin, you are?
Sorry, I forgot I had that responsibility.
So our, I'll just start talking, Justin, and then if I get pulled away, you'll take over or we'll tag team. Our call overview today, introductions, which Dan is going to lead, then a basic overview, going over our aims, a little bit of our key driver diagram and measures, starting to unpack the toolkit, 10 steps to getting started with basic, a description of our upcoming calls and timelines, and then leave some room at the end for questions. When we start a new initiative, we start with a kickoff call like this, and the rollout will begin and we'll collect baseline data and then start the initiative. Starting the initiative for our collaborative is not just turning on a light switch and everything starts at hospitals. Rolling out the collaborative and the initiative is a collaborative process. And so teams, we will grow as a collaborative, we will grow as ILPQC, we will grow as basic together. We will, ILPQC will receive your feedback and respond to that and develop more things that can be in the toolkit and adjust as we go through the initiative. For the past year, there has been a group of us that has been planning the aims, the toolkits, the driver diagrams, the measures, the data forms. So we're excited to start the initiative and introduce that to you today. Go ahead, Justin. So already, Dan, were you planning to go around and have No, there's too many people. I'm
No,
gonna
no.
kibosh that. I was like, oh
No,
my gosh,
no.
160 people. So
But,
we've already.
but Leslie, if people want to type in the chat their name and what hospital they're from, that is encouraged if you're interested. And
Okay.
Starting to build the basic community.
Great, that's a good idea. So we've already started planning our face-to-face meeting for people new to ILPQC. We have a annual face-to-face meeting for the OB teams and an annual face-to-face meeting for the neo teams. And this happens in May. And then we have our annual conference is held in November or the end of October each year. And so we've started planning our face-to-face meetings, and the date for the neonatal face-to-face is May 27th. This will also be a virtual meeting. It's a full day conference and collaborative learning amongst the teams, so please save the date. Annual conference is October 28th, 2021, so please also put that on your calendar. This is a less of a collaborative day, but some collaboration, more of a learning day, and it's a great conference. So please put this on your calendar. And so a little bit for new people, and for old people, some review about ILPQC structures and how an ILPQC collaborative works. So ILPQC is a multidisciplinary, multi-stakeholder perinatal quality collaborative with 107 Illinois hospitals participating in one or more initiative. And ILPQC covers greater than 99% of Illinois births. So we are a multidisciplinary collaborative. So there are people from all different disciplines involved in planning the initiative and rolling out the initiative and working on the initiative. And then we have multiple stakeholders, not only at hospital levels, but throughout communities within Illinois and within the entire state of Illinois. So our stakeholders are hospital stakeholders, they are community stakeholders, and they are state and legislative stakeholders. So here's our infrastructure. This is less of a hierarchy, more of just a schematic to show you how the ILPQC infrastructure. So we have OB hospital teams and neonatal hospital teams. The OB hospital teams and neonatal hospital teams are the foundation of our infrastructure. They are the people that drive clinical culture change, drive outcomes, drive improving the care and health of moms and babies in the state of Illinois. To support hospital OB and neonatal teams, we have an OB advisory work group and a neonatal advisory work group, and then our ILPQC central group, some of whom you have met today. And then, as I was talking about our stakeholders, we have state health agencies, associations, advocacy groups, regional perinatal system, patients and families, legislators, and then the Maternal Mortality Review Committee. And so hospital teams, both OB and neo side, are clinical advisors on the neo, and OB side are stakeholders in the community and at the state level, and also at the family level, all come together to improve the care of moms and babies within the state of Illinois. This is our ILPQ Central team. Ann Borders is our executive director and the OB lead. Justin and I are the neonatal leads. Patty Lee King is our state project director and our quality lead. Dan and Autumn are our project managers. Dan is a project manager, and Autumn is our nurse quality manager. Kalyan is our data systems developer. Aisha and Ellie are our project coordinators. ILPQC is built on 3 pillars. Whoops.
Sorry about that. I was going to say, do you want to just describe a little bit about how we're going to engage hospitals will engage with each of these individuals here. You gave them their titles, but
yeah. Dan,
interrupt,
why
but
don't you describe your job, Dan?
just in a real nutshell, and how, you know, you'll hear from all of us. You'll get to know all of our voices if you haven't heard us. And it'll be kind of nice to know what everybody's doing on the back end, because we don't see each other in person very often.
Yeah, no, that's a good idea. Dan, do you want to describe your role?
Sure. So we're kind of like a no wrong door approach in a sense, where you can feel free to reach out to any of us for anything and we'll get it funneled to the right person. But that being said, when it comes to anything regarding the data system, questions about data collection, access to REDCap, access to the data system and the data forms, if you notice any feedback or clarifications in regards to data collection, and then when the reports and graphs become live, I'll be the point person for that as well. I will, Ellie and myself will probably be the people who reach out to you all down the line when it comes time for recruiting teams across the state to share on our monthly webinars. Really, I'm like a Swiss Army knife. So just, you know, reach out with anything. And I mean, there's no face of this initiative, but think of me as I can help answer any questions. And if they're clinical, I will elevate them to someone who is clinical. So hopefully that was helpful. It was also very broad.
And Ellie, do you want to describe your role?
Yeah, so I will be kind of supporting everything that Dan said that he's going to be doing. So I'll be helping out with REDCap, helping get everyone access to REDCap and working on that. And then also probably helping with a lot of the communications about calls and, like Dan said, recruiting people to speak on our calls.
Thanks. Okay, go ahead, Justin. So here's a schematic of ILPQC and the 3 pillars that ILPQC rests upon. Our 3 pillars of support are collaborative learning, rapid response data, and QI support. All of the data, so starting with the middle, rapid response data, all of the data that you will enter for the initiative goes into our REDCap database, which can immediately, or pretty much immediately, put out data reports for your hospital that you can use with your hospital teams, with your leadership, with different stakeholders at the hospital. You can use them to drive clinical change. You can use them when we move into sustainability to make sure that the changes that you've made are solid. And you can also use them to help get champions and help talk with leadership stakeholders at your hospital. So the REDCap database is rapid response that we will look at as teams together to look at how the initiative is moving and how we're making clinical gains for the initiative. And then you can also look at your hospital team data. Collaborative learning happens usually within our monthly calls. We'll hear from teams and how barriers that they've overcome or successes that they've had at our monthly calls. It can also happen in smaller groups. Sometimes it can happen at system, or usually also it happens at system level. So hospitals that are part of a system can learn from each other. And then of course at our face-to-face meetings and our annual meetings, teams share and we learn together in a collaborative fashion. And then the 3rd pillar is QI support. Each of our monthly calls, including this one, will have some QI science or some QI support. Support can also be provided from ILPQC Central, and Autumn plays a huge, who's our quality nurse, plays a huge role in developing curricula, developing QI support, developing our QI corner on our webinars. And so there's lots of QI support that's provided. And so at ILPQC, collaborative learning, rapid response data, and QI support are the 3 pillars upon which we rest and drive clinical change. So just for people who are new to QI, what is quality improvement? Hospital QI work is looking at what changes you can make to your process or your system and testing it with a PDSA cycle to reach initiative goals. The model for improvement is one model for quality improvement that was developed by IHI, and this is the model for improvement that we use at ILPQC. There are other models that people use, and they're all kind of the same framework and the same idea. So the first thing we do is come up with an aim. What are we trying to accomplish? And for the past year, our basic group developed aims. We figured, what are we trying to accomplish? And so we'll see our aims in a little bit. Then we looked at we developed measures. How will we know that a change is an improvement? In order to know that a change is an improvement, you have to measure something. So we developed our aims and our measures to know that we're actually making changes. And then we said, what changes can we make that will result in improvement? Some of this is done on a global sense. This is what ILPQC thinks will, based on tons of feedback, some changes that we can suggest to teams. Some of these changes are in our toolkit, and some of it will need to be adapted specifically for your culture at your hospital. But what changes can we make that will lead to improvement? And then after you do aims, after you have measures, after you do your changes, you're going to do little tests of change. And this is trying out one change on a very small level and seeing what will happen. The first thing you do is plan what you're going to do. Then you actually do it. Then you look at your results, study it, and then you act. You say, oh, that went beautifully. We're going to just broaden that to a bigger group. That needs to be changed a little bit, so we're going to adapt it and then try it again. Or that was just horrible, that didn't work at all, we need to start over and plan something new. And in our upcoming calls, Autumn is going to go over plan, do, study, act, so we know how to, so each of the teams knows how to implement these at their hospitals. So that's just a little bit of foundation of who we are, what we've done so far, and where we're going. And now we're going to go over basic in general. Dan, you want to do this one?
Sure. So I think as of today, we have 70 hospitals signed up, which is awesome. And I would assume a large swatch of you, if not all of you, on this call are signed up because we have our communication list with the folks who have signed up. So if you're on this call and you haven't submitted a QI team roster, it is not too late. It's a great opportunity to become connected to the communication lists to make sure you're in the know with all the great things that will be shared across the collaborative. It's also the way that we are able to grant people access to submit data into REDCap. And so the link is right there. We'll post it in the chat for your, if you request or interested in getting it. And then for anybody on the call, some of you have already done this, but if you have any additions, subtractions, whatever, for your current roster that has been submitted, you do not need to submit a new roster through the link. You can simply email me your edits and I will work to incorporate those. And if you've submitted folks in the past and you realize that, you know, they want certain people didn't have initially REDCap access and you want them to have it, you know, just email me and we'll make it happen for you. So that's all I got on this slide.
Justin, you want to talk? You want me to keep talking? I'm happy to do either. I just don't want to monopolize the.
No, you can keep going for a while and either you'll get called away or whatever you need.
Okay, so many of you heard these are slides that were presented at the annual conference, but for people who were not at annual conference and just for review, why neonatal antibiotic stewardship? So antibiotics, as we all know, are essential in fighting infections in newborns, but there's wide variations in antibiotic prescribing for newborn infections, which can lead to unnecessary or prolonged antibiotic exposure that can result in short and long-term adverse outcomes, such as mother-baby separation, reducing breastfeeding and increased formula supplementation, impaired development of intestinal microbiome, longer-term chronic conditions that include asthma, allergies, obesity, and of course, antibiotic resistance.
I'm trying. Oh.
No, it's okay. So why did we choose BASIC? We chose BASIC for 4 reasons. ILPQC responded to feedback from ILPQC neonatal QI teams, the advisory group, leadership group, and the Illinois stakeholders. People said that at the end of each initiative, or as we're deciding on the next initiative, we ask for feedback and we vote on what the next initiative should be. So our stakeholders and our teams voted for antibiotic stewardship. We also thought that doing an antibiotic stewardship initiative supplements work that hospitals have implemented with Vaughn's antibiotic stewardship initiative. So many of our teams have done Vaughan work or have already done antibiotic stewardship work, and we are hoping to build on what hospitals have done so far, but also learn from the work that hospitals have done so far. The third reason is it addresses the critical importance, and it addresses critical importance and can affect all babies and hospitals at all perinatal levels. When 2 initiatives ago, when we did Golden Hour, that was mostly a NICU, or was really just a NICU project. And we saw with M&O that we were able to affect many more babies and engage many more hospitals at all perinatal levels. And that was something that was important to us and continues to be important to us at ILPQC. And so when we were choosing our next initiative, antibiotic stewardship allowed us to continue to engage hospitals at all perinatal levels and affect as many babies as possible within the state of Illinois. And then lastly, it builds on lessons learned from other PQCs who have proven effective strategies and focused aims to improve outcomes. So as with all PQCs within the US, we all learn from each other. We build on lessons and strengths that other initiatives have done before us. And so having had multiple PQCs that had done antibiotic stewardship initiatives, we were able to build and grow and learn from them. So we have built this initiative, and we are eternally grateful to all who helped to plan the BASIC initiative. Our BASIC Wave 1 teams, they reviewed our data forms and gave us feedback as to what didn't make sense, what needed to be improved, what needed to be changed. So thank you to our Wave 1 teams. Our BASIC planning work group, looking at our aims and measures, our key driver diagrams, our data collection forms, our quality improvement toolkit, and giving feedback, looking for gaps, searching the literature for things that can be added. And then our BASIC clinical leads listed here, developing the aims, the key driver diagram, the data collection form, the quality improvement toolkit, really getting into the nitty gritty and the weeds and seeing how a giant state initiative starts from nothing and then grows into something that can improve care for so many babies. So thank you to all of you. This is a list of our BASIC Wave 1 teams. Like I said, these are the teams that used our data form, looked at our data definitions, pulled data from their EMRs, pulled data from pieces of paper, and gave us tons of feedback so that we could make it as close to perfect as it could be for you.
Mm-hmm.
Justin, you want to do this? You want me to keep going?
I can.
Okay, go ahead.
I can let you hear a different voice. So, you know, with this whole building of this initiative is very collaborative. just like the way Leslie and I work together in a collaborative way. And so we're really happy, just if I could introduce myself just a little bit, to be doing this and to see this come to light. We're happy to have so many participants on this call today. And it really highlights the way hospitals in Illinois or that serve Illinois babies have really come together over the last few years. So we are really glad to be here. So basic aims, key drivers, and measures are what we're going to talk about next. One second. All right. So ILPQC basic. ILPQC hospitals, regardless of perinatal level or past experience with implementing newborn antibiotic initiatives, will implement best practices to provide the right antibiotics to the right babies for the right duration. And that's a key theme that we've already touched upon during the preparation process. In the process, and we'll continue to do that throughout this entire initiative. We have selected 2 key aims for this initiative: to decrease by 20%, or for hospitals who've done this work already, to have an absolute rate of 4%, the number of newborns born at greater than or equal to 35 weeks who receive antibiotics, and to decrease by 20% the number of newborns with a negative blood culture who receive antibiotics less than 36 hours. And this is our key driver diagram. It says draft, and it is to some degree a draft, but it's a very advanced draft, and it might even be to the point where we're nearing a final version. But we always think of things to improve upon as part of a quality improvement process. So by June 2022, if you're looking at the top left, ILPQC hospitals will, as I mentioned earlier, decrease by 20% or maintain an absolute rate of 4%, the number of newborns who receive antibiotics greater than 35 weeks or equal to. As a separate aim, decrease by 20% the number of newborns with a negative blood culture who receive antibiotics for longer than 36 hours. We, in putting this together, have identified primary drivers in 4.5 areas. I say the half because the first are in the first box. There are 2, but they closely link together, and we've lumped them together. So we want to, with the help of us, with the help of you, implement a QI infrastructure in your hospital that can accommodate this work. And so to work with the systems that you have in place and to help build upon them. And then, of course, we want to monitor and share transparent antibiotic data. And that we'll talk a little bit more about the data system a little bit later, although this is not a data training call, so we won't go over that in great detail. The next driver is to initiate timely and appropriate antibiotics. We'll consistently maintain, we're neonatologists, we see sick babies all the time. And we know that antibiotics do save lives. And so the goal is to not eliminate antibiotic use. The goal is to give antibiotics to the right babies at the right time for the right duration. And so we'll look at some change ideas to reduce the antibiotics that may not be necessary, or to decrease the time, which goes then to the next driver, to administer and de-escalate antibiotics. And so as our evaluation is ongoing, we want to help you through different processes to de-escalate, whether you're tailoring it to the specific bug that grows in a blood culture, or to stop it altogether once infection has been effectively ruled out. And then we'll talk about this a little bit more later as well, but we want to work on all of our initiatives to deliver equitable care for all of our babies and their families. on the write or change ideas, we'll actually break that down a little bit, and I'll talk a little bit more detail. So that's going to be coming in the next slides. We call this our deconstructed driver diagram, where we really dive just a little bit more deep into some of these things. So using data to drive change. So this is part of the quality improvement didactic that we want to sort of intersperse in here, just to talk about what kind of measures exist and how are we going to use different kinds of data to help improve, and how are we going to know that we improved if we implement some of these things that we're planning on rolling out. The goal of the structure measures is one measure that will be looking at, and the main goal is to make changes that lead to lasting changes. And I took some of this from the AHRQ, Agency for Healthcare Research and Quality, how they talk about quality improvement in these measures. And so they mentioned it gives a sense of a healthcare provider's capacity, systems, and processes to provide high quality care. For example, whether the healthcare organization uses an EMR or medication order entry system, the number of board certified physicians, the ratio of providers to patients. These are like just generic examples of what a structure measure might be to help kind of understand what's going on. The goal of these is to identify hospital level measures, policies, protocols, curricula for everybody that you encounter, to build a foundation that standardizes your system. Of course, there's going to be some standardized ILPQC guidance, broadly speaking, but you need to take this down then and tailor it to standardize it within your hospital. We know that every hospital is different. There's a hospital systems, and it gets down to each individual unit. And so how can you implement a foundation of standardized systems? And we'll help you get there. And then, one main reason of the structure measure is thinking about and planning for sustainability at the very beginning, so that, we don't want these initiatives to be 1.5 years of intense effort and then have that effort go to waste. We want these changes that we make together to be lasting. So with respect to structure measures, are the policies and practices in place that are needed to make systems improvements and facilitate culture change improvements. For ILPQC, they'll be tracked monthly, and they'll be in a stacked bar chart, which we'll show you an example of a little bit later. If you've been involved with the M&O initiatives, they'll look familiar to you. And if you haven't, they'll be new to you. So just looking generally speaking about the structure measures for this initiative specifically, we've identified structure measures for each of our key primary drivers. So in the data monitoring, transparency, and stewardship primary driver, the measures that we'll be looking at together are the percent and the number of providers and nurses educated on antibiotic stewardship and equitable care. Again, ILPQC will be hopefully, our goal is to be helpful every step along this way, meaning what that education might look like, how it gets delivered, is something that we're wanting to partner with you on trying to help that get out. Same thing applies to patient education. We want patients to understand why their children are on antibiotics, and we'll work together to create tools if they don't exist already, or assimilate tools from other sources. We will want to spend some important time early in the initiative looking at the EMR, and not just what goes into the EMR, but what we're able to extract from it, so that the data collection piece can be simplified. And so that the time that we're spending around quality improvement is working on improving quality not just, collecting data. The goal is not to just collect data. The goal is to use our data to drive important changes. And then have strategies to ensure that feedback is provided to the clinical team. For the primary driver of timely and appropriate initiation of antibiotics, we have several measures that we'll be tracking. We will be working with you to have a standardized risk assessment for early onset sepsis for every at-risk newborn. Many hospitals have implemented some version of this, and some have not, and some will all get there together. We want a partnership with our obstetric team to standardize communication about maternal risk factors for early onset sepsis, standardize the serial assessment of newborns, so that for those newborns that we do not begin antibiotics on, that we're able to identify who's at higher risk, who is having a clinical status change, and so that we can make a quick adjustment to what we're doing if necessary. And then for the primary driver of appropriate administration and de-escalation, we want to work to have standardized protocols to properly and consistently obtain good quality blood culture specimens. We want hospitals to partner with their lab to optimize timely processing of the blood culture results, and to optimize communication with the care team so that blood culture or antibiotics can be de-escalated when appropriate. Protocols to assist staff to stop or de-escalate therapy based on the culture results. We'll work to have dosing guidelines that are consistent, duration of antibiotic course at initiation, and some framework around when that de-escalation might happen, depending on the clinical course of the infant, and standardize automatic stop order processes. And then for our fourth driver, we are striving to include equitable care for all of our initiatives from here on out. We have strived that before, but we're going to put more concerted effort into creating a structure around that. And so by doing that, we want to standardize processes to review antibiotic data by race and ethnicity, to share with providers and staff, an implementation of a social determinants health tool, providing information at the right health literacy level. And again, we are eager to help design, create, and or disseminate this information that either exists or we want to create as part of this initiative from the ILPQC end, and to provide communication in a preferred language. So those are just kind of an overview of the structure measures that we're going to be looking at. This was a structure measure diagram that was used for a prior initiative. And you can see the goal is for all hospitals to get to the green. And so when we start out an initiative, if you look at your left side, in this case, there was baseline data on the far left. Many hospitals didn't have these measures in place. And over time, we worked together and they got the measures in place, by the end of the initiative. And as Leslie said in the beginning, this is a process, right? We're not going to have this initiative 100% ready to go on January 1st, in the sense that all the changes that we're working together on will take time. And we, of course, have to continue to move forward in time to get there, but they all don't start on January 1st. They start on January 1st, but they're not all done by January 1st or by the end of January. It's going to take time, and that's why these initiatives last the duration that they do. So that's kind of just an overview of structure measures. They're really hospital level items and measures. Process measures are a different kind of measure. And they look really at baby or patient. So process measures indicate what a provider does to maintain or improve health These measures typically reflect generally accepted recommendations for clinical practice. So some generic examples that don't pertain to this initiative: the percentage of people receiving preventable services such as mammograms or immunizations, the percentage of people with diabetes who had their blood sugar regularly tested or controlled. So there's a kind of different kind of measure to look at. The majority of healthcare quality measures are used for public reporting, that are currently used for public reporting, are process measures. And so as we think about these, are the parts or steps in the system performing as planned? So is things working as we're designing to, and are we on track to meet our goals and aims? And if we're not, how do we identify, what pieces that we need to work on? And these are patient level measures. They're tracked monthly, and they're on the clinical culture changes being implemented. These take the form of run charts, which we'll look through a little bit. Again, they'll look familiar to you if you've been a part of ILPQC initiative, and they might look familiar to you even if you haven't. And so some of the process measures that we'll be looking at are listed here. Percent of parents and families with newborns who received antibiotics who were provided education on antibiotics. Percent of newborns who received antibiotics with a risk assessment algorithm used and documented to evaluate the risk of early onset sepsis. That'll be a big one. Percent of newborns greater than 35 weeks who received antibiotics who used a risk assessment tool and documented that for early onset sepsis. Percent of newborns who received antibiotics with documentation of maternal risk factors for early onset sepsis in the pediatric chart. Percent of newborns with anticipated duration of course discussed by the clinical team, and percent of newborns with an antibiotic automatic stop time order entered into the medical chart. Again, we'll go into all of these in greater detail over the course of the coming months. And to some degree, we'll take everything that we've talked about regarding basic and deconstruct it into smaller pieces for us to work on in a time sequential way. And this is the example of the run charts that we were talking about. So if you look to the left, I don't know which initiative this was, but it was one of our formative initiatives. Is one of the process measures. And if you look, left side is the baseline, and you're able to track your progress as things go along. And then with the series of these, we have 5, 6, 7, 8 different measures, then we can see which ones we're making progress on and which ones we aren't making progress. And we can also identify if we're backtracking, which of course happens from time to time, where a process perhaps changes internally that may not be recognizable that it affects babies. And then of course, one final important point is, we always want to be careful with balancing measures, ensuring that there's no unintended consequences of quality improvement initiatives. And so that'll be important for us as well, just like with every QI initiative. So we'll just talk a little bit about the data. This is not a data call. We've had some data training calls. They're available for you to listen to. Are we going to have any more, Dan? Or is this the last? Have we had the ones that we have when we recorded the ones that we had?
So we have 2 recorded. I recommend, not because of anything about the first call, but I'd recommend watching the second one. You can get new things for both, but the second one, we learned some things and we're able to address them up front. And then, you'll be talking about this, Justin, but if there's any questions, people have already been chatting me privately on this, and, this is, we'll be sending, or if you can email those questions to us, because if you have that question, others probably will, and we try to compile that so that it's in an easy to understand place.
Thanks, Dan, and that is definitely true as we get to know, and that was one of the reasons we backtracked to make sure that we really introduced the ILPQC central team. There are things that are going to come up. There's questions that you're going to have. There's questions that you're going to have that maybe we hadn't considered addressing. And so, you know, send those through and we'll work through those together. ILPQC also goes through different PDSA cycles of improvement of what the content we're delivering. And we do that by learning where our deficiencies are and what we can work on. So there's kind of two different kinds of data that that we'll talk about. On the left side is an example of the paper version of the newborn data form. This would be entered into REDCap database. And then on the right side is the hospital level data. This is the structures and some data about your birthing volumes so that we can use this to determine what our rates of antibiotic usage are across the collaborative that you'll be able to use to determine the rates of antibiotic usage are within your own hospital or potential hospital system, depending on how you share data within your own hospital system. So just, again, this is not the data call. We'll walk through it just briefly so that people are familiar with what we're talking about, but we're collecting data on all newborns for all gestational ages receiving any IV antibiotics within the first 72 hours of life. We're not including newborns requiring surgical procedures or antibiotics for surgical prophylaxis within the first 72 hours of life. If a newborn receives antibiotics, is transferred, the receiving hospital will enter data on that newborn. That is a point of continued discussion about the best way to manage babysitter transfer because there's some data lost. But again, as we think about transfers, and we can talk about them in more detail at a different time, you know, the goal of this initiative is to satisfy our aims of the initiative, right? So it's to decrease the amount of antibiotics in the first, or by 20%, or to below 4%. So I don't want us to get too lost in the transferred piece. There's some elements of this that makes it a little bit challenging when a baby is sent somewhere or received from somewhere. But the goal is for all of us to improve and provide the best quality of care that we can. And the data will be submitted monthly for all newborns for that month who meet the following definition. I don't know what the definition is the following, but we will ask that the data be submitted by the 15th of the month for the previous month. So February 15th for January, for example. We are in a baseline data collection phase, October, November, December, and we're asking that to be collected by January 31st. It's always helpful to see where we're starting out, particularly before starting an initiative, so that we can track our own progress and, you know, you'll be able to see what you need to work on and what we need to work on together as a collaborative. And then as Dan mentioned, our calls were recorded and they're available with a link. There is a data dictionary with the definitions on the website. We've have had several iterations of that data dictionary, meaning as things became they might have been clear to us, but they weren't clear to others. We tweaked that. So if you're reading through and you're still not clear, reach out to us and reach out to Dan. Here we will update it on the website. Dan, do you want to just mention what's going on with REDCap?
Sure. So so in regards to REDCap, anybody who has submitted a QI team roster for basic, we have been working to add you into REDCap. That either means one of two things. One, you've done a prior ILPQC initiative and we're working to add those projects or data forms, the hospital level one and the patient level one, to your already existing account. Many people have already emailed me about password resets, etc. Don't hesitate to shoot us an email and we can make that happen. For those who have never had a REDCap account, we create the REDCap account for you. If your hospital email is prone to funneling external emails to your email quarantine, I recommend considering using a secondary email for the REDCap. It doesn't get spammed with anything, but it's a way to make sure that you can get your REDCap account signed up. And so anybody who is a first-time REDCap user, you will get an email that designates what your login is, or what your whatever it's called, your username is, and then it will give you a link to create your own password. If anyone is REDCap access and doesn't remember their password, email me and we will get you a password reset link. And again, if anybody on your roster is interested in REDCap access who doesn't already have it, email us. REDCap access means that access not only means that someone can potentially enter data, but it also means that they will be able to have access to view the reports. So it's not like a one person per hospital thing. If there's people who will be entering data and want to review reports, get them access. If there are folks who are on your team who are interested in seeing the reports but aren't going to be submitting the data, get them REDCap access. So it's a one-stop shop.
Yeah, and to be a little more specific about what REDCap is. REDCap is an online database. It's used by a lot of medical research systems, and of course we're not doing research here, but I mentioned that because it has the capacity to collect some patient data it's a HIPAA compliant way, although of course we aren't asking for a lot of identifiers on anybody, but it's a way to submit data electronically from your respective home sites. And the nice thing is that as soon as you submit your data, and after each and every patient, you can go and you'll be able to see the run chart reports immediately. So if you updated this month, for example, and you want to compare to last month, it's immediately available on the other side. Those reports we're in the process of building for you, like we did with M&O and like we did with the Golden Hour, and so that's what the REDCap is. It's simply a database system that we are using to help manage what the data that goes in, and then more importantly, the data that you can see on the way out.
Can I add one thing, Justin? Just because you brought it up, I think it's a good point. So we did submit this for non-human subjects designation at the IRB, and so it is not we do not require a data use agreement for this work, but if we know that there are some teams who like to have a data use agreement set up. So if you are, we've already had some teams reach out, but since this is a quality improvement initiative and it's a limited data set and none of the data that is submitted is backwards identifiable from what goes in the data system, we're happy to work with you on a DUA, but it's not required if you aren't interested in pursuing that. But email me if you have any questions.
So I alluded to this before, how often and when to submit data. So we have, of course, two data structures. One is the monthly data for patient level. This is data about babies who receive antibiotics. And that'll be on the monthly newborn data form. Some of you will be doing most of this or all this electronic, so the data form could be used as a literal form where that you could fill out, or could be just kind of a guidepost form that you would use to make sure that whatever electronic data that you're extracting from your EMR, aligns with the data that is on that form. And we'll be collecting data on newborns of all gestational ages receiving antibiotics within the first 72 hours after birth. And the other side is the monthly hospital measures. This is the structure measures that we talked about at the beginning. that I talked about at the beginning. And this is how this will allow you to track your QI system changes, how your education rollout is going, if there's new protocols or clinical practice guidelines that get rolled out, how those are working not only at your individual hospital, but across all of the hospitals in the initiative, mapping resources, process flow. And then we're also collecting, as I said earlier, some information about how many births in any given month that meet certain criteria, so that we can, when we know that a certain percent of, or certain number of babies were started on antibiotics, we know what that denominator is to track a percent.
Hey, Justin, can I throw out something quickly?
Yep.
Just so people are aware. So again, all of the most recent versions of all these data forms are going to be online on our basic webpage, which we will link in the chat. Obviously, they're live in REDCap for where you're submitting the data. We've created for the patient level data based on feedback we received from Wave 1 teams and teams with a data mined perspective. We've created one. There's the longer form for whoever want to use that, that have all the questions, but just on a couple pages. We've also created it as a two-sided one-pager in case you're interested in having all of the questions for a newborn condensed onto a two-sided one-page form. And then for those who really like it tight, for if you're going to be collecting stuff on at the bedside and you don't want to have a lot of paper around, we've also consolidated all of the questions, didn't remove any, but all the questions are on a one-sided one-pager. Those are all downloadable for your viewing pleasure on the basic webpage. But we wanted to just create a couple of different options that collect all the same data for the newborns, but for those who like having less paper, and for those who track any of their data on paper, we wanted to create a couple of different options.
Thanks, Dan. So as I mentioned, the baseline data period is October to December. And we're asking that data to be submitted by the end of January. And then of course the prospective data and the initiative, the initiatives are ongoing, right? It's an ongoing process, but in terms of data collection and monitoring, January 1st of this year, the turn of the year, is when that'll begin. And then there's some due dates there on the bottom that, hold on, I don't see very well because of my Zoom menu. Oops. So that'll be January 2021, due February 28th, but we'll, just to give you a little bit of a grace period for that first month, but we will shoot for the 15th of the month for the future months. So February's data will be due on March 15th, March data will be due on April 15th, and so on. I'm going to mention this briefly, and then Dan, I'm going to ask you to talk about what's coming. We're working on developing with some collaborative partners a new data dashboard to optimize your data review. We feel really strongly at ILPQC, it's one of our core pillars, that data is what drives change. But that data is not useful if you can't see it for your own hospital and see the things that you need to see, and see that in a way that not only will tell the story of what needs to happen for you, but also for buy-in for other key players at your hospital, administrators, and other leaders. And so we'll be looking at antibiotic prescribing rates with improved hospital comparison. So you'll be able to see how hospitals that are kind of like yours are doing in relation to your hospital. You'll have a monthly summary of key performance measures, and we're also making it a race and ethnicity sort of dashboard to also track equity pieces. And again, this will be in real time, meaning as soon as you put the data in, you'll be able to get that out. I don't know if you want to add to that, Dan. I haven't
Yeah,
see.
no. So
You've been working on it hard on the back end.
yeah, so the idea is that this is not going to be, it's going to be through the same portal. And once the data system reports are live, we're going to be holding training calls for those hosted by Autumn. But this is, these are all going to be, all of this data in these dashboards will be pulled from the same data universe that you were submitting for the newborns. So we're going to have process measures that are run charts, and to precede all of that, will on this through the same link, there'll be this first dashboard with what Justin was talking about. We're working to build it a little deeper. So I was talking with Autumn Perot, our nursing quality manager, and long story short, the way that we were thinking about the monthly line charts or the run charts is those are really the tip of the iceberg when driving QI, and if you're looking at your antibiotic prescribing rate, or the number of newborns who received antibiotics after 36 hours and it's going well, you can just nod your head and be like, okay, it's going well. Or on the flip side, if the data is going in a direction you are not anticipating, you kind of, you shrug your shoulders, but there's a line chart. And so, there's only so much you could do with just looking at run charts. And so the idea with the dashboards is we want to have it look a little bit underneath the surface of the water and see what else is driving quality care. And so what will, in addition to some of what we call the key performance indicators or key performance measures that are called out for you to see right away, we're also going to be building these tables that can pull up cases that may, or newborns who may have fallen out of care, so that you can see right away the cases that you cared for that might be causing your numbers to go in a way that is not what you anticipated. So, we're still developing that, but there might be, you might get a report out of all the newborns who received antibiotics after 36 hours with a negative blood culture. And then you can see right up front the reasons why and make determinations about, okay, did they truly need to receive them, or can we use this as a learning opportunity and think about in the next month, what are small tests of change that we can incorporate to help prevent any unnecessary additional antibiotics. So we're creating this dashboard for tools for you to dig deeper and drive the change at your hospitals, in addition to celebrating the data and the performance that you're going to be making over the course of this initiative. So hopefully that helps. We'll have that probably by April for your viewing pleasure. Viewing and action.
Great. Hold on. So next I want to transition over just to talk a little bit about the Toolkit. Like all of our initiatives, ILPQC develops a little committee to identify, to vet, to look through all of the different resources that might be available that you could either use as is, things that we need to develop as a collaborative that don't exist, or things that you could adapt or adopt to tweak your local needs. And that can be a variety of things. This year, we are doing it all online. There is not going to be a printed toolkit this year. We found with the M&O project that although we printed things out, things got added so quickly. We made so many new materials. We identified new materials. Things were made by other hospitals or organizations that went on the toolkit that it was really the online piece, the fact that it could be sort of alive, that made it the most valuable. Our toolkit sections are sort of concentrated with our drivers. We'll have some initiative QI and some data resources. We'll have some national resources and guidance. We do want everything that sort of we recommend and everything that we move toward to be based on the best clinical evidence at that time. And so we want to be transparent, not just with ourselves, but with the other stakeholders within your hospitals who, as you're making changes, there's always people and processes that need good evidence. And so we want to be able to provide that for you. Driver 1 is data monitoring, timely administration of antibiotics, appropriate administration and de-escalation, and equitable care delivery. And so these on the right are kind of some examples of some things that will be in this toolkit, including this clinical report put out in 2018, which is a key paper, and AAP guidance from the American Academy of Pediatrics. And then the website itself, ilpqc.org/basic2021. See, this is just a snapshot of kind of how it looks there. We've clicked on driver 1 on the left side, and that's pulled up some resources. We have things that we don't have ready yet. We've identified placeholders of things that either that we're going to create or we need to identify. But as we find things or create things, this is where we'll put them. So at this point, I'm going to hand it over to Autumn, if that's okay, Autumn. And you know, we've presented a lot of information so far, but we want to try to make everything that we're talking about as tangible as possible, so that you'll have some good strategies to start, you know, at the new year to work on specifically. So, you there, Autumn?
She didn't confirm when I said, do you want to do 10 steps? She didn't answer, so I can do it though.
Okay, I'm going to hand it over to Leslie then. We didn't ask Autumn before, but she put a lot of effort into it, so I wanted her to have a chance to present her own work. I feel guilty presenting somebody else.
If she comes back on, we'll transition to her.
I think she's working through some technology stuff, so I see her on
That's all fine, but I'm going to hand it over to Leslie so that you can hear a new voice for a little while.
Okay, thanks. So some of you have seen this at our annual conference. We went over steps 1 through 5. And so Autumn and I together developed 10 steps to prepare for basic and what you need to do starting here. So we've divided it into 2 slides, 1 through 5 and then 5 through 10. Or 6 through 10. So schedule your regular basic QI team meetings. So at your individual hospitals, schedule your basic QI team meetings, a monthly meeting of the whole group, and then smaller meetings of subgroups if that needs to happen, but make sure you have a regularly scheduled basic QI meeting. And so hopefully teams have started doing that. If not, that should be your first step. And then attend QI team lead support calls. So there's a provider and a nurse champion team call that Autumn has developed that are phenomenal. She did one in the beginning of December or end of November, I'm not sure when it was. And then at the end of our slide set today, there's another one coming up that I encourage all of team leads to attend. And this call will help you understand what is QI, what's a basic initiative, what do I need to learn and do to lead my monthly QI meetings? How do I set up an agenda? How do I drive change? How do I talk to hospital leadership to get them invested in the basic initiative? So these are great calls. There's one recorded, and then there's another backed by popular demand, upcoming one. The third step is to review your ILPQC basic data collection form and discuss strategies for data collection. So look at both the patient level and the hospital level data forms and talk with your team about how are we going to collect data? How are we going to get all of this data either onto the paper form or and then into REDCap, or from the EMR directly into REDCap. Who's going to do it? How often are we going to collect it? When are we going to look at data reports together? Then work with your QI team to complete the basic team's readiness survey. With each initiative, we have a readiness survey that helps individual teams identify areas for improvement, but it also helps ILPQC identify collaborative-wide areas for improvement and focus some of our monthly calls. So the readiness survey is now available on the website, and so encouraging all teams to fill this out, and there's a due date of January 18th. So filling out your readiness survey together as a group and then submitting it by January 18th. The 5th step is creating a process flow diagram to reflect your current process for antibiotic decision making. Some hospitals have QI people on their basic team, and other teams don't. If you have knowledge and a skill set to create a process flow diagram, then we're encouraging teams to start that process. If you don't have that skill set yet, it will be part of Autumn's QI provider and nursing lead call, and so understanding how to do that. And then, so what a process flow map does is it says from beginning to end what your process is, for example, with basic, what your process is in communicating with OB, assessing a baby's risk for early onset sepsis, plus or minus starting antibiotics. How do we stop antibiotics? How do we make sure that a baby doesn't get sick if they're not antibiotics? So writing out the whole process from beginning to end for early onset sepsis. And then your 6th step is, after you have that process in place, identifying opportunities for improvement. Oh, here's an area we don't get the information that we want in an easy way from OB. We can make this part better. We have no way to stop antibiotics at 36 hours or 48 hours. It's completely random. There's a tremendous amount of variation in our practice within the hospital. There's a place for improvement. So looking at your whole process and being honest, bringing all of your team members together so you can get all different points of view, being honest with yourself and your hospital and saying, this is an area for improvement. This is an area of improvement. Here's where we can improve care. Here's where we can improve outcomes. So after your process map, identify opportunities for improvement and possible interventions. And you'll look at our the basic key driver diagram to match things up and see where areas of improvement and things you can do are. After that is step 7, reviewing the ILPQC basic online toolkit for nationally vetted resources to support your improvement goals. So matching up your areas of improvement with tools. This is an area that I think we can fix. Oh, here's some tools we can use to fix this. And this will be happening not immediately. Step 6, 7, 8, 9, 10, those will start after the first couple of months of the initiative. 8, though, can start earlier. Creating a 30, 60, 90-day plan to identify what you want to accomplish in the first 3 months. So big initiative goals, you'll be doing 30, 60, 90-day plans.
You have a Mac, right?
Yes.
Do you,
Can you guys mute yourself if you're not talking?
I got it, Leslie.
Thank you. So we'll create a 30, 60, 90-day plan under Autumn's guidance of what we want to accomplish in the first 3 months of the initiative. And then throughout the initiative, you can create additional 30, 60, 90-day plans. You'll do one chunk of it in the first 90 days. And then if you feel like that's going to take you longer, you may not need to create a 30, 60, 90-day plan. But if there's another big area of focus, 30, 60, 90-day plans can help you really focus on, this is the area we want to improve, here are the tools we're going to use, and this is what we're going to do to improve it. And once you've done your 30, 60, 90-day plan, creating small PDSA cycles. As I talked about before, planning what you're going to do to drive change, doing what you're going to do to drive change, looking back at the results of what you've done, and then adapting, adopting, or abandoning what you've done. So doing small cycles of change. So 30, 60, 90-day plan says we're going to do this within the first 3 months, but 6, 7, 8, 9, and then 10, reaching out to ILPQC for help. We'll start doing these over the first couple of months of the initiative. That's all I got for that. Autumn, are you back on? Well, thank you to Autumn for developing that. I think it's really, we all think it's really helpful to get teams going and what they need to, and understanding what they need to do with the first steps. So I alluded to in the first 1 through 5, basic readiness survey. The basic readiness survey is live. It's important for everybody to complete for reasons that I said. It helps you identify current barriers and opportunities at your hospital. It helps ILPQC know how to best support you, and it helps identify leaders in various components of the basic initiative to help. You can, the link is here, but Dan, how can they do it if they don't?
Yeah, so it's
on the website?
Yeah, so it's on the website. We've also posted it in the chat. So there's many different roads to get to it, but it's on the basic 2021 webpage under the toolkit, underneath the QI initiatives and data resources section.
Okay, great.
So, or just email me. I got you guys.
Thank you. I said January 18th. I think apparently we changed it to January 15th. So readiness survey, work with your team to complete your readiness survey by January 15th, 2021.
I snuck that little change in because I thought if we have it by the 15th, maybe we'll have some data to share with all of this group.
Oh, good idea. Yeah.
And I don't know if we'll be able to analyze it or not, but there'll be no chance if the data is not in. So.
Okay.
Hold on, I'm going to get you a new slide. I think the readiness survey is something that we've kind of worked to create. I don't think it'll be very hard. I think if you find the right person who knows your processes in your hospital, whether it's you or somebody else, they're going to be able to churn through really quick about how things work within your hospital. So I don't think it should take very long, assuming you can find the right person who knows the answers to the survey questions, if you will.
Okay, basic timelines and thanks, Justin, and webinars. So November, we had excuse me, ILPQC basic data calls and our QI leader support call. There is a recording. In December, where we're in pink, we're having our official kickoff today, and then team webinars will start in January, and then begin your baseline data reporting, which is from Q4 of 2020. In January, your readiness survey is due 1/15/2021, and then your baseline data reporting is due 1/31, and then monthly reporting begins after that. And then this, oh, go back one, Justin. There's the data training calls are recorded, and those can be found, as Dan said, listen to the second one, because some of the things in the first one, feedback was then switched and put into the second one. So if you need to listen to or want to listen again to a data training call, those are recorded and can be found at the ILPQC website. The QI Leader Support Call. So we are so excited to announce that we will be hosting an encore QI Leader Support Call. So if you are a team lead, a nursing lead, or a physician lead, like I was saying, this webinar will outline what it means to be a QI leader for upcoming ILPQC initiatives, and will share strategies to help lead a successful QI initiative. We encourage all QI team leads, providers, physicians, nurse champions, and actually anyone who wants to help lead the initiative to join this call. And on it, there'll also be, oh, we already said this, discussing strategies to be an effective leader on a QI team. So it's January 7th from 12 to 1 p.m. And Dan will—
This all came about because you know, we were asking rosters to be submitted, and we were asking for quote unquote physician champions and nursing champions. And Leslie and I think Dan were having questions saying, what does it mean to be a physician champion? Like, what is that? How do I do that? Or what kind of responsibility is that? And so the ILPQC central team has created some support around, you know, helping you be as effective as possible in your own hospitals to drive change. So I've heard really good feedback from the first two that were done. So if you haven't done it and you're on one of these rosters, which you are because you're on this call, we encourage you to participate on January 7th.
And Dan, do they have to register, or how will they?
Yeah.
Oh,
I think
yeah.
it's just a
Like
Zoom link. Wait, for the call previously, or what on this
For
slide?
the team lead, the nursing physician team
Yeah,
lead.
it's just a Zoom link. You register, but it's not like you could. It's like any Zoom link you may have seen over COVID. It's like you register and it gives you the link to join. So it's not. It's not like a annual conference registration or something.
But did they? If there are people, what if they're not getting emails from you? They can look on the website?
Yes, every link should be on the website. We'll add it to the basic page so people will know.
Okay.
And we can also add it to the chat here. This is Autumn, everyone. So we'll have Ellie add it.
Yes, I did post it in the chat, but I'll post it again because it probably got.
Yeah. I did want to bring that up, and I think this is probably as good a time if any. But if there's, so we want to make sure that everybody has access to communications because communication is key, and just to know what's going on. In a pinch, if there is something that is, you could always reach out to us. If there's ever a question about when a call is happening, or if there's a resource available, everything should be on the basic webpage. On the main page of the ILPQC website, we have an enhanced calendar events section that is a calendar view of an entire month, and it hovers, and if you hover over certain days, it will give you all the calls. One thing we've also done, as it shows on this slide, is we've transitioned to Zoom, so no more WebEx. So for those of you who liked WebEx, I'm sorry, and those of you who don't like Zoom, I'm sorry, but this is what we'll be using. It's, I think, a little more user-friendly. And so we tried to make it so that you can register for the meetings so that you can, and by registering it, it lets you create a recurring calendar invite. So it can get it on your calendars to make it easier to hold the block of time every month.
Great, thanks, Dan. The first one, obviously, you're in this, so that's happened. And then moving forward for our 2021 monthly webinars, there will be monthly basic team calls on the third Monday of the month from 1 to 2 p.m. Central Time, and that's starting in January. Autumn, I heard you, but you were kind of cutting in and out. Is your audio working?
Can you hear me now? Hello?
Oh, perfectly, yeah. I tried to do your steps 1 through 10 justice. I hope I did it. But can you introduce yourself so everybody knows who you are and your role in ILPQC, and start to learn what a tremendous resource you are?
Oh yeah, happy. Thanks, Leslie.
Everybody else introduce themselves.
Yeah, no, I heard that. That's okay, not a problem. So hi, everyone. My name is Autumn Pro. I'm the nurse quality manager, and I have the privilege of working on a lot of quality improvement documentation and just being a resource. So always feel free to email the info account or myself personally. I'll put my name and my email in the chat, and we're always there to help with anything you might need.
Thank you. Go ahead, Justin. So some of our basic webinar topics for 2021 will be energizing teams, and then going over to the toolkit and how to use those tools with your teams, learning about the neonatal early onset sepsis calculator and other risk assessment tools, how to use your EMR for moving this initiative and making the initiative work well and easy. Trusting the blood culture. How do we know if it's okay to just look at a blood culture? Implementing antibiotic stop times. Culture negative sepsis. What is it? Why do we treat it? When should we treat it? Doing clinical assessments. What's the frequency? How do you develop a process in your hospital to do clinical assessments for babies who are at risk for early onset sepsis, either on antibiotics or not on antibiotics? Partnering with OB teams so that communication and information is as seamless as possible. provider education, making sure that all providers, nurses, pharmacists, the entire team is educated about early onset sepsis and knows about the ILPQC initiative. Patient education, and then disparities in neonatal early onset sepsis care. There is not a lot, if any, work in racial and ethnic and inequities and outcome disparities in antibiotic stewardship in the neonatal area. And so the first months of our initiative, we're going to be collecting data and just trying to understand where areas of inequity and disparities are. And so the first part of 2021 will be collecting data, and then at the annual conference, hopefully, or maybe, I mean, face-to-face, or a little bit after that, depending on how much data is collected and what we can glean from the data, we'll start to focus in on areas of inequity and disparities. So at ILPQC, we have a commitment to equity in neonatal and pediatric QI initiatives. And some of the areas that we hope to address this as we get more information and a better understanding is to provide training and education in social determinants, cultural sensitivity, and implicit and explicit bias. Obviously, this can be done, this applies to all areas of medicine, not just antibiotic stewardship. And so that we can start even before we have data. Creating a dashboard to identify and reduce inequities and disparities. So something to look at quickly and understand, and to be able to understand and assess our hospital landscape. Providing a standardized tool for screening of all families for social risks and social support. This is something also that we can start sooner. We don't need our antibiotic stewardship data to be able to start this work. Creating alliances and partnerships with community organizations, understanding what community alliances and partnerships can help move, decrease inequities and disparities. And then beginning discharge planning and family education and admission tailored to each family's needs and in their preferred language. That work can also start soon. So we are excited and committed to decreasing inequities.
I changed these slides around a little bit, Leslie, and
I know, I'm like, oh.
so I don't want to throw you off, but I just
I
want
was rounding.
more introduction to what we're doing. I thought this is a little clear. So we are having a patient family engagement pilot, and if any of you are interested in getting a small group and one-on-one support from Latasha Rouse, who's a national patient advisor, she's a QI expert, to engage families and patients in your QI work, there's an opportunity that will be available to you. Who is that? Which is why I added some slides, because I knew who she was because we had her speak at the annual conference. If you were at our annual conference, she was talked about her patient experience and was also in one of the breakouts for the family centered care. But she is doing, so she had 26-week triplets and had, of course, a long NICU journey and had some postpartum complications as well. And she's really able to speak with her experience in the NICU and speak to her experience as a patient herself, and has really taken it upon herself to become a leader in partnering with families to allow them to be a part of the QI process. She's very good at this. The AP has recognized her, and I got this from the American Board of Pediatrics website, where Dr. Wanda Barfield, who you might recognize from the CDC, she's in charge of the Division of Reproductive Health at the CDC. And she's a good partner with ILPQC. We know Wanda very well. And so she's doing an amazing work to give parents an audible voice in the NICU. she's improving the quality of parental involvement and care of their critically ill newborns. So I think this is a good opportunity to have somebody who knows how to engage families, who's also experienced it herself. So this will consist of a series of 5 sessions that occur monthly, and we'll start in mid-January. It's a pilot for the ILP. You'll be able to pilot the patient family engagement toolkit, and she'll provide custom education support program. So we hope that you can consider that. Obviously, it's a pilot. We don't expect everybody on this call, obviously, to be a participant in it. But we've locally at our own hospital, with statewide with Illinois, and we've really wanted to engage with patients more, and it's not easy, which is why we talk about it, but it's hard to do. So this is an opportunity. So if you email the info@ILPQC by January 7th, you can be a part of this pilot. Anything else on Tasha?
No, but I wanted to bring up something, and this is very early news, but we'll be rolling it out in 2021. We are working to grant offerings to all Illinois hospitals participating in our QI work, or ILPQC hospitals, so includes the St. Louis metropolitan area. But we are working to get access to the Institute for Healthcare Improvement Open School, which is a great program for building structural understanding of the basics of quality improvement in healthcare. And so we'll be working to grant a couple offerings for folks at each hospital in our collaborative. And so, of course, anyone who is a learner or a resident automatically has free Institute for Healthcare IHI access already. But for anybody who is not a learner at an institution, we'll be working to reach out to hospitals to see if there's 2 or so representatives who will be interested and able to join the cohort of learners to really help continue to reinforce and build quality improvement expertise across the state. So more information about the logistics of that will come out in 2021, but just wanted to get you all excited for those of you who are interested in flexing your QI muscles a little more. We have some tools that will come out to help with that.
Yeah. So this is a slide for the physicians on the call. The American Board of Pediatrics does provide Part 4 credits for this kind of work. So just a reminder for those of you who participated in M&O work, you can submit a form for your M&O work. But I really wanted to focus on the basic. It has been submitted to the board and has been approved for 25 credits for 2021. It's not a catch, but you do have to meaningfully participate to claim those credits. And meaningful participation, according to the board, is intellectually engaged in the planning and executing the project, implementing the project's interventions, reviewing the data, and collaborating actively by attending team meetings. And so I think at ILPQC, we've seen that as, that you're regularly going to your monthly meetings, that you're regularly reviewing your data with your team, and you're regularly and actively engaged in promoting and improving the interventions and improving the quality in your hospital around antibiotic stewardship. So we're excited, and in the fall again we'll send out the information about how to submit a form to get that credit.
So these are for review. the 10 steps to prepare for basic, schedule your QI meetings, attend your physician RN lead call, review the data collection form and discuss strategies for data collection with your team, work to complete your basic readiness survey that is due January 15th. Start to create a process flow diagram of your current process for antibiotic decision making. Start to think about opportunities for improvement. Review the basic online toolkit and to support your improvement goals. And then when we start webinars, we'll start talking about 30, 60, 90 day plans, or when you start working with Autumn, PDSA cycles. And then as always, reach out to ILPQC for help and celebrate your successes early and often. I think we've said this a million times. Basic readiness survey, January 15th. Begin data collection for your baseline Q4 2020, which is October through December 2020 data. The data forms open December 1st, 2020 for those who had requested REDCap access. If you don't have REDCap access, Dan described how to do that. Add info@ilpqc.org and Dan's work email to your safe sender list so that it doesn't go to different areas, and then email info@ilpqc.org or Dan with any questions. And that's all we have. So thank you to all of our funders. And now we have about a half an hour, 25 minutes for questions.
So yeah, I think we could probably, I think this is, if Leslie and Justin, you can stay on, I think this is a good time for anyone who wants to ask questions.
Yeah.
I did get one question privately that I thought I could probably post for your initial insights, but
okay, so right, but they said that her symptoms were worsening, so you should really
oh no, PHI being shared on a recording.
Okay,
let's mute them. Okay, cool. All right, so that was that. So I had a question from someone who I didn't link their name, but so this hospital mentioned that as it currently stands, they give 4 doses of AMP at 0, 12, 24, and 36 hours. A new order needs to be entered if antibiotics are going to continue. Otherwise, there are no antibiotics at hour 48. They're interested in knowing, is the expectation that we not give the dose at the 36 hour, or if cultures are negative at hour 36? So does that 36 hour dose happen, or is it any after that from a negative blood culture?
You want me to answer, Justin, or you want to answer?
You can.
The 36-hour dose is fine. It's any dose after 36 hours. But I think that's, Dan, important to look at our data form, which I don't have in front of us. Does it say greater than 36 hours or greater than or equal, like less than? Let's make sure that if you get a dose at 36 hours, the data definition isn't.
Yeah, we can look at that. So that's a great question by Tina. So Tina asks, so the 48 rule out, or so the 48 rule is out the window. I think that's a good concept to address.
Go ahead, Leslie.
Meaning that you don't go to 48 hours. Yes, so the majority of cultures, if they're going to turn positive, will turn positive actually within the first 24 hours. And so when we created the initiative, we felt safe saying stopping antibiotics at 36 hours was safe, or we felt secure in saying that stopping antibiotics at 36 hours is a safe practice. So one of the goals of the initiatives is to go from 48-hour rule out to 36-hour rule out.
And in the data form, we tried to designate that there are some teams that we want to know the distinctions between the 36 and 48 hours as well. So we didn't just try and create it as a binary option.
Yeah, and there's some statements in the chat about past 48 hours, less than 48 hours, and we are working to provide fewer antibiotics, starting it less often when there's not clear indications, and to stop it when sepsis has effectively been ruled out. We know different hospitals have different needs in terms of where their blood cultures go, what their turnaround time is to get some sort of result, how often they're checked, are they on a continuous machine or checked periodically, and so we are trying to work to make an initiative that will accommodate everybody's needs, while also moving toward the collective goal of less antibiotics. So that is how we're approaching this. So out the window maybe isn't the right word, but we want fewer antibiotics when it makes sense. And as I said at the very beginning, the goal is not to eliminate antibiotic use. It's to give it to the right baby for the right duration, etc. There's a question in the chat box about IRB. We talked about this a little bit earlier. No IRB is needed. The Northwestern is applying for an IRB exemption, or it's in process or been processed, but it's not human subjects research that we're doing. There aren't identifiers, and so all of our initiatives have met that IRB exemption for quality improvement.
Or if you happen to have a separate quality improvement committee, like we do at University of Chicago, that you're aware of, then what we do is fill out the forms and send it to those guys, and they end up signing off on it as QI.
I want to go back just a second to the data form. Justin, I think this was answered. Sorry, Joe, that I was reading this in. Past 48 hours, greater than 36 hours, less than or equal to 48 hours, less than or equal to 36 hours. What Justin, I think it was addressed enough that some reporting systems from the microbiology lab may be different or are different at different hospitals, and also hospital culture is going to be different, and there may culture, not blood culture. It may be hard to just say we're going from 48 hours to 36 hours, and we may need for some hospitals to kind of do stepwise improvement, and that's why all of those are in the data form. The data form will also help us to focus. If everybody's still saying we're doing 72 hours, or everybody's saying we're doing 48 hours, then we know in monthly data calls where to focus some of our improvement in our toolkit.
There are some questions about the transfer babies in the chat box. We are working to make sure that we get this right. We've had a couple different proposals. And so we will put out some clear communication soonish. It won't be before the holidays about transfers, just for clarity. But like I said earlier when I was talking about it during the presentation, we want to be as good as we can with the transfers, but the goal is to improve the quality that we provide, and to reduce reduce antibiotic and be good stewards of antibiotics. And so I don't want to get all of us to get too hung up on the transfer. We want to be as right as possible, but the goal is to provide good care, particularly, well, not particularly, to provide great care. Not that we aren't providing good care, but to provide a QI structure around that.
Tina, yes, we're going to go over right antibiotic, right baby, right to all of that. And so what are recommendations for antibiotics at in general, and then at your individual hospital?
And it's one of the questions that we're asking for on the survey, is to get a sense for what's currently being done. So there's a question about capturing information about babies that had a blood culture drawn. We aren't looking for individual, that's not on the patient level data form for whether a blood culture was drawn or not. It's a question that should be ascertainable from the EMR, hopefully through an electronic query of just how many blood cultures within the first 72 hours were drawn on infants. One of our main early phone calls for this will be is how to engage your EMR, the people that help build it and collect and are able to obtain data from it, so that you can have a more systematic approach of data assembly that hopefully will be extractable from either most of it or all of it, depending, can be extractable from an EMR. So that's, we're working, we'll be working with you for that.
There's a question about, we have been using the sepsis tool when we started our antibiotic stewardship. How does this affect data? So we have two aims. One is to decrease by 20%, and one is less than 4%. And we specifically put that less than 4% in because we knew hospitals had been working on antibiotic stewardship, and saying decreasing less than 20%, decreasing by 20%, decreasing by 20%. Some hospitals who have already done fabulous work in antibiotic stewardship wouldn't be able to decrease by 20%. And so there is a bottom that hospitals who have already done work can work towards. Any other questions?
Always submit them to our info account or individual. This is our mascot for basic, or at least one of them, Sunny.
Hi, Sunny.
Sunny the antibiotics dog.
Joe, did you have a question?
Yeah, yeah. It's just that when I got the list for the baseline data, there were like 100 babies. And I know we talked a little bit. Are you still there?
Yeah.
We talked a little bit about trying to figure out if I really need to go through all 100 charts at baseline, or should I just plan on doing that?
I'm feeling bad, but I would plan on doing it.
So okay. Joe, I've done over 40 for October, November for Evanston. So it's not 100, but it takes about 5-10 minutes per chart.
Okay. All right.
Yeah, we're doing the same thing down here. Trying to divide up this number of charts.
All right. I will get going.
This initiative's gonna be a labor of love.
Yeah.
Oh, and we also looked at the number of babies who were submitted into the data system for golden hour per month per hospital. We were seeing, there were some, it was NICUs who were participating, but there were high numbers on a monthly basis for golden hour. So I'm not saying that, that's probably not a helpful comment, but from perspectives, that level has been done. It's not going to be, unfortunately, M&O where some people have no data to submit, but yeah.
I'll just keep Stella, my therapy dog, near me.
Should be a mascot too.
I think it's important to get that baseline data because in the level 3 nurseries, you're really going to be looking at not necessarily should you have started, but should you have stopped the antibiotics.
That's an important point, Matt, and just for any of you all hospitals who are the receiving hospitals, when it comes to this is just a data piece, just for you all to know, we're going to be removing so y'all will be tracking data on folks who are transferred in, but we will be taking their initiation rates out of your receiving hospital's initiation rate for any who were admitted to your own hospital, so that you can see what your institution's true initiation rate is without looking at the newborns who most likely were coming in on antibiotics anyways, just for context.
And there's some other questions that I see in the chat box that kind of are around different aspects of the initiative that'll roll out dosing regimen. And that's all really important, and we all want to address that. But as Leslie said at the very, very beginning, it's going to take some time for us to get through all this, and we're not going to have everything. You're not going to be ready to implement everything that there is, on January 1st. We saw with the structure measures, with the green chart, it takes time to get all the way there. And so that'll be the focus of one of our calls, and there'll be a time where we're working on the dosing and the frequency and that. So we've presented a lot of information. We asked for 2 hours today, and we're grateful for your time for it. But the goal isn't for us to tell you everything you need to do in 2 hours. We're all working on this together at roughly the same pace. And although 18 months happens very, very quickly, it's not going to be next month. So we will have time, sort of, but 18 months goes by very quickly.
And there is one question about babies admitted in the first 72 hours to the emergency department. I think those babies should definitely be included because they may have been a missed opportunity for antibiotics at birth. And so those babies should be tracked if the data can be collected. It may be tricky if they come to a different emergency room than where they're born. Sorry, yours.
I would anticipate relatively few coming through that mechanism within the first 72 hours. There will be few depending on the hospital structures. But, if it's standard vaginal delivery is typically, 48 hours, and unless COVID has shifted things around and babies are getting readmitted at a much higher frequency, which is possible. Well, I think we should probably wrap up. We are so thankful for your time. Thank you for giving us 2 hours. We know it's too long. We'd like to keep these calls at an hour. We know that all of our schedules are terribly busy, and an hour is difficult in and of itself. But there was just too much information today, and we didn't think we could give any of it justice. So we're thankful for your time. We're super excited about this initiative. To the planning committee, we thank you for all of your hard work. This is seeing it come to fruition is fantastic, and I look forward to seeing our run charts showing improvement.
Thanks very much for the info.
Thanks, everyone. We'll send out We'll send out a recap along with information about when the next calls are and all that fun stuff, and distill this call for you all. So happy holidays, be safe, etc.
Same to you, Dan.
I'll try.
And Justin and everybody.
Bye.
And Goose.